Hello, everybody. Welcome to our module on kidney stones. Kidney stones are also called nephrolithiasis, and there are four types of kidney stones that you should know about. There are the calcium stones, the struvite stones, the urate stones, and the cysteine stones. We'll talk about all four in this module today. There are some common symptoms to all types of kidney stones that you should be aware of, and the first one is flank pain. So that's pain that's located on the side between the ribs and the hip, and that's where the pain is often located in patients who have kidney stones. Patients with kidney stones describe the pain as colicky. So what do I mean by that? That's pain that waxes and wanes in severity. And patients with kidney stones will describe waves of pain that sort of come and go. And then finally, most patients who have kidney stones have hematuria from damage to the ureters and collecting system by the stone. There are some common risk factors to all types of kidney stones that you should know about. And the first is to have a high amount of a stone-forming substance in the blood. So if you have hypercalcemia, you are more likely to get a calcium stone than someone whose calcium levels are normal. If you have hyperuricemia, you're more likely to get a uric acid stone than someone with normal urate levels in the bloodstream. Secondly, if you have a low urine volume, which is usually from dehydration, you get increased concentration of substances in the urine, and this means that stone-forming substances can precipitate out into kidney stones. And in general, hydration is a potential treatment for all forms of kidney stones. If you keep more fluid flowing through the bladder and the urinary system, you will flush out those substances that lead to stones. So the first type of stone we'll talk about is the most common type, and those are calcium stones. These are usually calcium oxalate. That's the most common type of calcium stone, but sometimes, less commonly, they're calcium phosphate, and these account for about 80% of kidney stones. Key risk factors are hypercalcemia. So if you have high levels of calcium in your blood, there's more calcium in the urine and you can form these stones. Also, if you have high oxalate levels in the blood, you can form the calcium oxalate type of calcium stones. And these are radio-opaque stones, so you can see them on X-ray and CT scan. And there's a picture of one on this CAT scan over on the right. You see this white thing here, which is in the ureter, and it's very small, but there shouldn't be any white substance there. And the reason it's white is because it's got calcium in it. So this is what a calcium stone looks like on a CAT scan. The most common etiology of calcium kidney stones is idiopathic hypercalciuria. So what do I mean by that? These patients have high levels of calcium in their urine, and we don't know why. That's why it's called idiopathic. They do not have hypercalcemia. They have normal calcium levels in their blood. Less commonly, patients will actually have hypercalcemia, and this can be from a number of causes, but the most common is hyperparathyroidism. Other risk factors are high oxalate levels. So why would you get high oxalate levels in your blood? Well, patients who have Crohn's disease cannot absorb fat. They have fat malabsorption. And fat will bind calcium in the gut, and this will leave oxalate free to be absorbed because normally calcium and oxalate are bound together in the gut. But when the calcium gets pulled out by the fat, the oxalate is free and it gets absorbed, and therefore patients with Crohn's can have high oxalate levels in the blood, which sets them up to have calcium oxalate kidney stones. Patients who've had a gastric bypass can also have fat malabsorption and can also get high oxalate levels in their blood. A very rare risk factor is patients who have ingested ethylene glycol. Either it's a child who ingests it accidentally or an adult who has a suicide attempt. Ethylene glycol is antifreeze. And if you ingest this, you will form oxalate in the blood and you will get high oxalate levels in the urine. And then finally, patients who take way too much vitamin C can generate oxalate levels that are very high in the blood because oxalate comes from the metabolism of vitamin C. So the classic case of a patient who has a calcium kidney stone is a patient who's drinking less water for any reason, or maybe they're outside on a very hot day and they're dehydrated. They develop flank pain and hematuria. On imaging, you can see a calcium stone, and they will have normal calcium levels in their blood, but they will have increased calcium levels in their urine because remember, the most common etiology is idiopathic hypercalciuria, which means high levels in the urine but not in the blood. Let's talk about the treatment of calcium kidney stones. Most stones pass on their own. So patients will be treated with hydration, maybe IV fluids. They'll be given pain meds to get them over the colicky pain. But then after a few hours or few days, the stone will pass. Very large stones sometimes won't pass and will require surgery. And if patients have recurrent stones, they can take medications to make it less likely that they'll have a kidney stone. There are two options for medical therapy. The first are the thiazide diuretics. These cause patients to resorb calcium, so there'll be less calcium in the urine. And as you know, one of the side effects of thiazide diuretics is hypercalcemia. That's because it pulls calcium out of the urine. But that's helpful for patients who are kidney stone formers. And then the second treatment option is citrate, which is taken in the form of potassium citrate. This binds with calcium in the urine but remains dissolved, so it lowers the urinary calcium that's available for stones, and the net effect is that you get inhibition of stone formation. So either of these two drugs are options for patients who get recurrent kidney stones made of calcium. There's an important relationship between dietary sodium consumption and the amount of calcium in the urine that has to do with kidney stones. So when you consume a high sodium diet, this expands your extracellular volume. Your body holds on to extra water when you consume extra sodium in order to keep the plasma sodium concentration normal. The expanded ECV will dial down the renin-angiotensin-aldosterone system, and this will lead to less sodium resorption in the proximal tubule. In the proximal tubule, sodium resorption and calcium resorption are tied together. So when there's less resorption of sodium, there is also less resorption of calcium. This means more calcium is in the urine when you are consuming a high sodium diet. So the key points I've summarized on the right side of this slide. More sodium in the diet equals more calcium in the urine. So a high sodium diet can lead to stone formation and is a risk factor for calcium kidney stones. A low sodium diet is a potential treatment option for calcium kidney stones because it will reduce the amount of calcium in the urine. Next type of kidney stone is the struvite stones. These are stones made up of ammonium, magnesium, and phosphate. They are the second most common type of stone, responsible for about 15% of kidney stones. And they are a consequence of urinary tract infection. So I always remember the U in struvite stands for UTI. If you get a UTI with urease-positive bacteria, these are bacteria like Proteus and Staphylococcus and Klebsiella, these all hydrolyze urea to ammonia in the urine, and therefore the urine becomes alkaline. And an alkaline environment is what creates the formation of struvite stones. So a very high yield thing to know about struvite stones is that they can form something called staghorn calculi. So let's talk about what we mean by that. If you look at this X-ray image on the bottom right-hand corner over here, you will see that the entire collecting system of the kidney is bright white. It almost looks like someone's injected dye into the collecting system of the kidney. But in fact, all this white stuff is stone material that's precipitated out and essentially formed a cast of the collecting system. And that's a staghorn calculi. It's a huge collection of stone material, and it looks like the horns of a stag. Now, obviously, something that big is not going to pass on its own through the ureter and into the bladder and out in the urine, so surgery is going to be required. And if this doesn't get treated, it becomes a reservoir for bacteria, and patients with struvite stones that go untreated can get recurrent infections. And obviously, these are radio-opaque stones. You can see it on X-ray and CAT scan, just like in the image over here on the screen. So the classic presentation of a struvite stone is a patient who has UTI symptoms like dysuria and frequency. They often have mild flank pain. Because the stone is high up in the kidneys, the flank pain isn't always as intense as when patients have stones in the ureter with calcium. They'll get hematuria, and then they'll show you the imaging often with those large branching staghorn stones present. And the treatment is to do surgery to get the stone out and to give antibiotics for the infection. Next type of stone is the uric acid stones, and these are relatively uncommon, and they're caused by either a high uric acid level in the urine or an acidic urine. So the way these stones form is that hydrogen ions present in the urine react with urate ions and form uric acid. So if you have a very acidic urine, you have a lot of H+ around, or if you have high urate levels in the urine, both of these things predispose people to get uric acid stones. A very important point to know about these stones is that they are radiolucent, so they will not be visible on X-ray. You can, however, see them with CAT scans. And the lowest pH in the nephron occurs in the distal tubule and the collecting site, so this is a common place for uric acid to start to precipitate out of the urine. Remember that in the collecting duct, hydrogen ions are being secreted by the cells into the urine, so the pH gets very low there, and that's where uric acid stone substance can form. So what are the risk factors for uric acid stones? Well, if you have high uric acid levels in the body, you can get uric acid stones. So patients with gout have high uric acid levels sometimes. Patients who have leukemia or myeloproliferative diseases can have high cell turnover, and all that metabolism and cell turnover increases the uric acid levels. If you have an acidic urine, this will precipitate uric acid like I showed you on the last slide. Patients with chronic diarrhea tend to have acidic urine, and therefore they can get these stones. And then finally, these stones are more common in certain climates. So in hot, arid climates, people have lower urine volume, and they tend to more commonly have acidic urine, and they will get these stones. So for example, in the US and Europe, only about 5 or 10% of stones are uric acid, but in some other climates like Egypt, these stones can be as high as 40% of all kidney stones. An important thing to know about the treatment of these stones is that you can usually treat it medically. So if you hydrate patients, and then you make the urine alkaline, this will often dissolve the stone. So we administer potassium bicarbonate to patients with uric acid stone, and that, along with hydration, will often dissolve the stone and make it go away. Rarely we have to give patients allopurinol. This is a xanthine oxidase inhibitor, and it reduces uric acid production. So the bottom line is that medical therapy is often effective for these stones, and patients usually don't require surgery, even if the stone is large. So the classic case is a patient who has typical stone symptoms like flank pain and hematuria, and then they will often tell you there is no stone on x-ray. And many times the question will ask for therapy, and the key point is to choose medical therapy, not surgery, even though there may be a large stone. So the last type of stone is a cystine stone. This is a very rare type of kidney stone, and it's seen in children with a condition called cystinuria. So these children have a tubular defect and cannot absorb cysteine, and they're going to form cystine stones. And it's important to know that these type of stones can also form those staghorn calculi that we talked about with the struvite stones. So the classic case is going to be a child who's got no history of a UTI and forms a large staghorn stone. And remember, struvite stones are going to be in people with history of urease-forming bugs in their urine. So they're going to have a UTI going on. This will be a child with no UTI with one of those large staghorn stones. And the treatment is hydration and alkalization of the urine, just like for uric acid. And that concludes our module on kidney stones.